Now let's go through some of the causes of acidosis and alkalosis. We start by looking at the arterial pH. Let's say there's an acidemia, meaning the pH is less than 7.4. What will be some of the causes of acidemia or a low blood pH? In order to figure out if this is a primary respiratory or a metabolic process, let's look at the PCO2. What's a normal PCO2? Right, 40. If the PCO2 is greater than 40, then we know that this is at least a respiratory acidosis. This will be caused by anything that causes hypoventilation, such as acute lung disease, chronic lung disease like COPD, opioids, sedatives, or weakening of the respiratory system, as in amyotrophic lateral sclerosis. Now, if the PCO2 is less than 40, then we know that the acidemia is caused by a metabolic process. Now, what if the PCO2 is less than 40? Then we know that the acidemia is caused by a metabolic process, and respiratory compensation is happening. We then want to check the anion gap. Do you remember how to calculate this? Correct. It's the sodium concentration minus the sum of the chloride and bicarb concentrations. What should a normal anion gap be? Well, a normal anion gap is between 8 and 12 milliequivalents per liter. This tells us if there are any foreign anions in the patient's blood, because these foreign anions are acids that have donated their hydrogen ions to the blood. Causes of an increased anion gap metabolic acidosis can be remembered with the mnemonic mud piles. This stands for methanol, which forms formic acid, uremia, diabetic ketoacidosis, propylene glycol, iron tablets or INH, lactic acidosis, ethylene glycol, which forms oxalic acid, and salicylates. This list is incredibly high yield and will certainly appear on some, if not all, of your exams on test day. Commit these causes of anion gap metabolic acidosis to memory. If the patient has a normal anion gap but still has a metabolic acidosis, then the causes of this can be remembered by the mnemonic, or all adults here, hard ass. This stands for hyperalimentation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, which is a carbonic anhydrase inhibitor, spironolactone, which is an aldosterone antagonist, and saline infusion. Why does diarrhea cause a normal anion gap acidosis? Well, both sodium and bicarb are being lost in the stool, and looking at the anion gap equation, this will show that the anion gap would not change. But because bicarb is being lost, there will be an acidosis in the body. The most likely to show up on your tests are diarrhea and renal tubular acidosis, so be sure to go back and review these. Now let's look at the causes of alkalosis, or an elevated blood pH. What is the next thing you want to look at? Well, that's the PCO2. If the PCO2 is less than 40, then what type of alkalosis is this? Well, this will be a respiratory alkalosis, which will be caused by hyperventilation and thus blowing off lots of CO2. This can be caused by hyperventilation at high altitudes or even during a pulmonary embolism, where the patient will increase ventilation to increase oxygen saturation but reduce PCO2 in the process. Salicylates can also cause hyperventilation because they increase the respiratory drive. Now, what if the PCO2 is greater than 40? Well, this means that there is a metabolic alkalosis with respiratory compensation. Metabolic alkalosis results in the increase of plasma bicarb, and it's usually associated with dehydration. The dehydration is needed in order to maintain the high bicarb levels, because a normally hydrated person can excrete large amounts of bicarb very quickly. This is called contraction alkalosis. What are some causes of metabolic alkalosis that you can think of? Well, vomiting, which results in the loss of hydrochloric acid, and hyperaldosteronism, which causes increased hydrogen ion secretion in the collecting tubule. Remember, vomiting causes alkalosis because you're losing all that hydrochloric acid, and diarrhea causes acidosis. Metabolic alkalosis can also be caused by loop diuretics and antacid use, which also increases hydrogen ion secretion. Now let's work through a quick problem. A patient comes in with morphine overdose. You check his arterial blood gas, and his pH is 7.25 with a PCO2 of 60. In order to figure out what type of acid-base disturbance this is, let's follow the algorithm. First, look at the pH. Since it's less than 7.4, this is an acidemia. Now that we know it's an acidemia, we have to figure out if it's metabolic or respiratory. Since CO2 functions like an acid, a high CO2 level would point to a respiratory acidosis as the primary disturbance. This patient's PCO2 is 60, so it's high. And if you look down the list, you see opioids listed as a cause of respiratory acidosis, which makes sense. So this patient has a respiratory acidosis. Flash quiz. What is the primary acid-base disturbance when the arterial pH is greater than 7.4 and the partial pressure of CO2 is greater than 40? Well, this is metabolic alkalosis. Next, a 65-year-old alcoholic presents to the emergency department unconscious. When you talk to his wife, you find out that he drank wood alcohol or methanol because he ran out of vodka. What would you expect his blood pH, bicarb, CO2, and anion gap to be? In order to answer this question, you need to know that methanol causes a metabolic acidosis because it gets converted into formic acid in the liver. This means that the patient would have an acidemia with a pH of less than 7.4. He's going to have a low bicarbonate level since metabolic acidosis is caused by lowered bicarb. He's going to have a low CO2 due to hyperventilation as respiratory compensation, and an elevated anion gap since formic acid will produce formate, which is an anion. And how do you treat methanol overdose? Well, the two most common ways would either be ethanol therapy or hemodialysis. Now let's finish off renal physiology with a quick discussion of renal tubular acidosis, or RTA. These are a type of acidoses, so they do apply in the schematic we just discussed, but they're special because they result directly from dysfunction in the kidney. Type 1 is also known as distal renal tubular acidosis because it results from a defect in the ability of the alpha intercalated cells in the collecting tubule to secrete hydrogen ions. Now, quick question. Why would this result in a hypokalemia? As sodium is reabsorbed in the collecting tubule, this creates a negatively charged lumen potential. Normally, both potassium and hydrogen ions flow into the tubule to balance the charge. Since hydrogen ions cannot be secreted in type 1 RTA, more potassium will move into the filtrate. There is also an increased risk for kidney stones because the urine will have a higher pH, thus making it easier to precipitate calcium phosphate. Causes of type 1 RTA include amphotericin B toxicity, analgesic nephropathy, and multiple myeloma. Type 2, or proximal renal tubular acidosis, results from a defect in the proximal tubule's ability to reabsorb bicarbonate. However, the ability of the alpha intercalated cells in the collecting tubule to secrete hydrogen ions is intact. This results in decreased pH of the urine as the body tries to compensate for the acidemia. There is also hypokalemia. Now, why is this? The bicarbonate that has failed to be reabsorbed in the proximal tubule travels to the collecting tubule and brings sodium along with it. As the sodium is reabsorbed in the collecting tubule, it will create a higher negative lumen potential. This will result in increased potassium and hydrogen ion secretion into the filtrate. Causes of type 2 RTA include Fanconi syndrome and proximal tubule toxins like lead and aminoglycosides. Lastly, we have type 4, or hyperkalemic renal tubular acidosis. This results from hypoaldosteronism, or the inability of the collecting tubules to respond to aldosterone. Therefore, the hydrogen ion and potassium secretion are both reduced. This type is most commonly seen in the condition of diabetic nephropathy. Well, this wraps up renal physiology. Good job for getting through that. Let's finish it up with a USMLE style question. A 6-month-old girl is brought to the ED by her mother after ingesting a bottle of unmarked pills from the family's medicine cabinet. On examination, the child appears agitated and tachypnic. Urgent blood chemistry measurements are taken and reveal the following: sodium 143, potassium of 4, chloride of 104, a bicarb of 19, and a pH of 7.28. Which of the following medication did this patient most likely ingest? The correct answer is C. This patient is suffering from an acidosis because the pH is 7.28, and we know that it's a metabolic acidosis because the bicarb is 19. When calculating the anion gap, we subtract 123 from 143. This is sodium minus the chloride and bicarb. This gives us an anion gap of 20, which is elevated. Therefore, we know that the patient has an elevated anion gap metabolic acidosis. The only one of these answer choices that causes this is iron supplements. Alright guys, well done. You guys are doing a really good job. Let's take a quick break and I'll see you for the next lecture.